This presentation is adapted from Session 1 of Pulmonary, Sleep, Cardiology, and Critical Care Academy, an online CME-accredited course for advanced practitioners and physicians. Today, I'd like to review a quick and easy approach to identifying simple primary acid-base disorders.
Before we go further, I just want to show you our acid-base display convention. Not every hospital goes in this order, but to keep things simple, I'm not going to label the acid-base problems. It makes my slides a lot cleaner. But I place pH, PCO2, PO2, bicarb, and saturation in just that order. I have the normal values listed here. And an example without any labels would be 7.40, 40, 80, 24, and 98. That's a perfectly normal blood gas with the labels as mentioned. So let's jump right in. To identify a simple single acid-base disorder, we simply start with the pH. If the pH is normal, we typically have no acid-base disorders. That's the most common. But it is possible to have 2 or 3 acid-base disorders that cancel each other out and make the pH normal. So a pH of 7.40 by no means that there is no acid-base disorders. If the pH is high, that's how we define alkalosis, an elevated pH. To determine which type of alkalosis, we look at the PCO2. If the PCO2 is low, we have alveolar hyperventilation. We're blowing our PCO2 down, and that's a respiratory alkalosis. If the PCO2 is high, then we know it's not a respiratory alkalosis, so it must be a metabolic alkalosis. On the other hand, if the pH is low, we know we have an acidosis, and the same logic applies with hypercapnia or alveolar hypoventilation. When the PCO2 is high, that's how we define a respiratory acidosis. And if the PCO2 is low while we have a low pH, then we clearly have a metabolic acidosis. Now, primary respiratory disorders have acute compensation. So when we have a primary respiratory alkalosis, there is an acute small drop of the bicarbonate, about 1 for every time the PCO2 falls 10. So for example, a patient has acute hyperventilation, their pH is very high at 7.57 and their PCO2 is quite low at 22. Notice that the bicarbonate is 22, not 24. That very small change of about 2 for about a 20 drop of the PCO2 happens acutely. There's no time delay. This is not a metabolic, this is a buffering reaction. We'll get to that a little bit more in a minute. And a respiratory acidosis, a similar but opposite thing happens. When the PCO2 rises, the bicarb rises 1 for every 10 rise of PCO2. So for example, here we have someone with acute hypercapnia, possibly a drug overdose. The PCO2 jumped up to 70, so the pH is quite low at 7.21, but the bicarb is up about 3 or 4 at 28 because the PCO2 went up 30. Now, the bicarb of 28 is an acute change. It did not take any time. It happened simultaneous with the PCO2 rising. Now, there's also a chronic compensation to respiratory disorders. In chronic respiratory alkalosis, the drop of bicarb is by the kidneys, not just buffering. So chronically, the bicarb falls until the pH is close to 7.43. So in this example, this patient's PCO2 has been low at 22 for several days, so the bicarb has had time to fall to 14 and corrects the pH, not all the way back to normal at 7.40, but close to normal at 7.43. The opposite happens with chronic respiratory acidosis. The bicarb is retained by the kidneys over hours to days and rises to keep the pH close to normal, but still a little bit low at 7.37. In this case, a patient has chronic hypercapnia with a PCO2 of 70 chronically, and the bicarb has gone up to 39 to correct the pH almost back to normal at 7.37, still a little bit acidotic. Now let's talk about compensation to metabolic disorders. Since the compensation to metabolic disorders is quick, that is, the compensations through respiratory changes, the chronic compensation to these metabolic disorders is the same as the acute compensation. They both happen over just several minutes. So in a metabolic acidosis, whether it's acute or chronic, the compensation is respiratory and the patient hyperventilates to drop their PCO2. So for metabolic acidosis, we actually can predict how low the PCO2 will go by using Winter's formula, or also called Winter's prediction. The expected PCO2 is calculated by multiplying the bicarbonate times 1.5 and adding 8. Our answer to that equation is plus or minus 2. So for example, if this patient has a metabolic acidosis, in this example, the bicarbonate is 10. We expect the PCO2 to be 1.5 times 10 plus 8. So 1.5 times 10 is 15 plus 8 is 23. The PCO2 of 23 is exactly as expected, but the range was plus or minus 2, so anything between about 21 and 25 would be close enough. Now, in metabolic alkalosis, there can be a compensation of rising PCO2, but that is very unpredictable. Some patients don't retain any CO2, some retain just a little bit, some a bit more. So we don't really have a Winter's formula equivalent for metabolic alkalosis.
You should now be able to identify a simple acid-base disorder and recognize the metabolic or respiratory compensation to single disorders. The next steps in acid-base analysis are appreciating degrees of compensation, recognizing the presence of a second primary acid-base disorder, and exposing hidden or complex acid-base disorders. If you'd like to learn more, please visit our educational center at pulmonaryandsleepacademy.com, where we have 70 hours of self-paced online CME-accredited courses covering pulmonary, sleep, cardiology, and critical care medicine. Please enjoy more of our short visits on our PSA YouTube channel. You can purchase our full courses with an exclusive 10% discount code using YouTube10.